how can you verify on clinical examination whatever you have seen? Like, for example, I can give you lead, like patient vertical gaze was normal. It means brain is midbrain
Yes.
was okay. That is fine.
Yes,
Yeah.
sir.
Now, patient doesn't have a
Yes, sir.
corticospinal sign. Patient doesn't have a cerebellar sign. Okay. There is no sensory impairment.
Yes, sir.
It means most likely patient
Yes, sir.
medulla is normal and major part of pons is also normal.
Yes, sir.
Lower
If
cranial nerves also not involved.
cranial nerves also not involved.
Yeah.
So if a significant part of pons will be involved, then you will get much more things. It will not remain confined only to diplopia and facial nerve palsy.
Yes.
And the patient has vertigo and vomiting, dizziness and vomiting. Most likely, there was associated ischemia of vestibular nuclei as well. It may not be visible on MRI initially. Maybe if you do a repeat MRI after some time, you may get it that the lesion was extended even to vestibular nuclei.
Yes,
Okay.
sir.
So, and how can you differentiate between lower motor neuron facial palsy and upper motor neuron facial palsy? What are the features on which basis you can differentiate?
Sir,
Can you suggest?
wrinkling of the forehead, we will see first. It was present in the lower motor neuron facial palsy.
It will be present. Now, please.
Absent in the lower motor neuron facial palsy.
Yes. Yes.
So, and then we will look for the
The most obvious is the eye
upper half of
closure.
face.
Whether the person can close the eye or not. That is the most prominent thing.
Yes, sir.
And besides this, in upper motor neuron facial palsy, there is dissociation of facial expression during emotions. They will be present, but voluntary movement, it will be absent. If a lower motor neuron type, emotional as well as a voluntary, both will disappear. Okay. So on examination, you got the most important finding which you got, which suggests central nervous system involvement on in brainstem is horizontal gaze palsy and INO.
INO.
And on the basis of that, you can hypothesize that the seventh nerve nucleus or its fascicle is being involved along with it. The most hard sign which you have of CNS involvement of brainstem is of pons is gaze palsy and INO. So you should put your coin on these two physical signs. Okay. Facial nerve palsy, you can explain because they're nearby. There is a facial nerve nucleus on the basis of which can be involved. And vestibular ischemia can explain the patient dizziness and vomitings. So you can explain all the lesions on this basis. Did you examine fundus of that patient? What was the vision of that patient?
So vision was normal. We examined the vision by Snellen's chart. It was 6/6. And so fundus was also normal. There was no papilledema or any disc changes.
No, if you are looking for a demyelinating lesion,
Yes.
what will you look in fundus?
Also, optic neuritis.
Optic neuritis is acute presentation.
You
may get signatures of previous optic neuritis if a patient has any suspicious history of visual impairment or because he has a history of right hemiparesis.
Optic disc,
so you should always be cautious to find out whether I can on clinic examination, can I find something which will contribute towards demyelination or it is only vascular? That is my point of saying.
Temporal paleness.
Okay, so you can go ahead with the etiology. Yeah, on MRI, what it showed.
So before we go continue with the permission of the chair, I have a comment on this cardiovascular point that you have mentioned about that the patient was having history of cyanotic heart disease and recently probably having reversal of the shunt. When you say it is reversal of the shunt, do you expect that P2 to be like H2 to be wide and fixed? because in classical ASD without pulmonary arterial hypertension, the second ultrasound is wide and fake splitting is the
Yes,
classic finding due to delayed pulmonary valve closure. But once you have Eisenmenger syndrome, that is severe pulmonary arterial hypertension with reversal of the shunt, how can you expect this wide splitting? Because the P2 will come closer. So in severe pulmonary hypertension, in a patient who is having cyanotic heart disease in the form of atrial septal defect, the S2 will be, what will be the S2? It's not
It will be wide and fixed.
wide and it is narrow, or it will be single ultrasound, or maybe paradoxical.
Yes, sir.
Reverse splitting. So
Sir.
correct it, because maybe in the examination you get only Eisenmenger without any neurological part. So in that point of time, you'll be asked this type of question. Here you are getting
Yes.
more and more neurological findings, so everybody is concerned. But in a patient who is having ASD with Eisenmenger, with history of that particular hemiparesis, maybe that is there, may not be there, but be careful about telling the auscultative finding, because S1, S2, it has definitely got significant clinical value. Clinically, when you diagnose, you have to be very careful.
Was an echo done? Was an echo done?
Yes, sir.
What are the findings of the echo?
So he is coming.
Sir. Findings of echo, sir.
Yeah.
Sir, he is coming to the etiology and then
Sir,
probably
findings also,
investigation.
sir. First cyanotic heart disease, ASD with reversal of the shunt.
So right to left, sir, instead of
Yes, sir.
left to right.
Yes, sir. Reversal.
Sir,
Right to
please
left.
continue with the etiology. Yes.
Did you get the echo done, Dr. Ritesh, of that patient?
Yes, yes, ma'am.
Yes.
So what was the finding in echo?
He just said,
ASD, ma'am, with ASD with reversal of the shunt.
Of the shunt was the, okay.
Yes, ma'am.
But-
From the right to left shunt was there.
But merely telling ASD is not enough with reversal of the shunt. You have to specify whether it is ostium secundum ASD, whether it is ostium primum ASD, whether, so that is important. Be very specific, because in echo you can actually pinpoint whether there is a fenestrated ASD, whether there is reversal of the shunt, whether only there is ASD in this case, but maybe at times you may get PFO. And if the PFO is not detected in these type of cases, we do some specific type of echocardiography.
Sir, actually, we did not allow them to see the echo and MRI findings.
Okay,
We did not allow them, right?
Okay.
So, so to just be, we wanted it to be just a clinical presentation without
Right.
any bias, right?
Yeah.
yeah, just a point here. Sorry for a bad throat, but being an internist, just like what Dr. Tapas said, when the patient presented with a history of previous congenital heart disease and embolic stroke, my first concern would have been to look at the heart first and put this as a vascular origin neurological deficit straight away without thinking of anything else. I would have gone to the heart first, got a cardiologist's opinion, and then think about neurology. Because that is a consequence of the primary lesion. That is neurology.
Patient, I think, sir, was admitted in neurology ward, not in medicine ward.
That's the problem. That is the problem.
Yes.
Once it goes to a super specialty,
Yes.
they see with the tubular vision. But we internists see the holistic approach.
Agreed,
So
sir.
this
Absolutely
patient should
agreed.
have gone through a holistic approach. I mean, that is why it is better to get into medicine ward, examined by the internist, and then take opinion of the various specialties. And that lesson must be told to all super specialty hospitals.
Agreed, sir. Absolutely
Only
agreed.
in this
Thank you.
case, there is only one challenge, that thrombolysis, in the era of thrombolysis, You have to thrombolize within 4.5 hours, and now it has been extended to 9 hours in selected cases. That decision primarily becomes important in this scenario. So maybe thrombolysis is something which has to be spread. The algorithm and the understanding and the guideline has to be taught. Only then that is possible, because even now thrombolysis is not being done as often as it should be done.
I agree. I agree fully, sir. The thrombolysis is not, even the patient is not aware, and even largely the doctors are not aware. And a whole set of team is required for thrombolysis, which in small town centers, the full setup is not available. So I think the thrombolysis thing, although we in our center are doing once in a while, but definitely need
But
of.
now we have tenecteplase, which is a bolus injection, and
But
they say that you can do it based on CT also.
Shamshi, the problem is like our problem is different in comparison to the problem where you work. Like we have to convince every family member.
That is different issue.
That is like there are various social issues. Sometimes when patients comes in window period, it becomes difficult for us to pursue them for thrombolysis. If you pursue 10 patients, one will agree at the most. In that pursuance, the golden period that washes away. This is the biggest problem. And they are not willing to accept any negative aspect of thrombolysis. So sometimes, despite of window period, we face so many problems. Dr. Smita has said it's a really big problem for us. Yeah. But we are always for thrombolysis. So, what is the further workup of this patient is planned?
Sir, further workup, firstly, sir, we will do
Basically
MRI
on
of the
investigations, basically.
investigations, sir, we will
do
go
you
for the
plan now?
MRI brain. Sir, firstly, blood investigations we will do and then on radiological investigations, we will plan for the MRI brain, and also MR enterography we can do.
Okay.
MR angiography, and
what purpose you will solve by doing MR angiography?
sir, the occlusion or any lesion we can see the.
Agreed. Like in this case,
yes, sir.
there you suspect very tiny lesion, which is confined to a very small area. Okay.
Sir, before going to MR angio, let them answer why you are going for a complete blood count. What is the importance in this patient? This is a basic. And what is the next investigation after the CBC? What do you expect in the CBC and why? And what is the next investigation in this patient from investigation point of view for blood test? The second one, I am giving you a clue that we want to do one coagulation profile, because this is basically a hyperviscosity syndrome. Is it? So what is the importance of CBC?
The patient may have secondary polycythemia due to hypoxia and cyanosis. The patient
because
may
of
have
chronic hypoxia.
Yeah. D-dimer,
Yes.
sir.
So chronic hypoxia in Eisenmenger triggers erythropoietin production, which increases red cell mass, and this causes hyperviscosity, increasing the risk of venous thrombosis, not arterial thrombosis.
Yes.
And what is the importance of iron probe studies and the coagulation profile? Because this is the question you will be asked in the examination, may not be the MR angio.
Sir, basically it is a hypercoagulable state.
Yeah.
So just because of that, we will do the coagulation profile and also proceed with the D-dimer also to look for that.
No, hypercoagulable state because of what?
Yeah.
That is important.
So since it is a case of stroke in young, we would also like to rule out protein C, protein S deficiency.
Once there is an existing disease which can explain your hypothesis,
yes.
Will you look for thrombophilia factors?
Yeah. No, sir.
No.
In
The
this
patient-
case, what is the reason of hypercoagulability in this case?
Polycythemia.
Secondary to?
Secondary to uh, reversal of shunt and hypoxia.
Hypoxia second.
Yes.
And this type of patient is also prone to having iron deficiency, other than the coagulation profile abnormalities. And that must be ruled out, as this RBC, which are actually defective, are less deformable and this increase the risk of stroke in polycythemic patients. In one hand, you are getting polycythemia. On the other hand, we are getting iron deficiency. And the RBCs become less and less deformable, which increases the risk of stroke. And that probably is the mechanism by which this patient is having recurrent stroke once in the earlier period with the hemiparesis, and now he has presented with all these cranial nerve and brainstem features. So this is very important.
Yes, sir.
So it's a very complex hemodynamic status.
So my question, to the internist is, I think we should go for Holter also for a long term. Maybe he's having associated arrhythmia also.
Yes,
Yes,
sir.
sir.
Yes, sir. Correct. Mhm.
Yes.
And even in investigations, though there is no history of fever, still I would like to exclude SABE through investigations. Yeah.
Yes, sir.
Yes,
Yes,
sir.
sir. We go for
Yes, sir.
echocardiography.
Echocardiography.
And
Yes.
microscopic hematuria, what we used to read that
So
urine.
in early times we used to do, but
Yeah.
nowadays no one is doing. Directly we are
Okay.
going for echocardiography. No
Okay.
one is looking for microscopic hematuria
Okay.
and
Okay.
routine
Yeah.
examination.
Yeah. My point was that
Yeah.
though there is no fever, but still we should look
Yes.
for.
Yeah. We must look for in
We
this.
must,
Right.
SABE.
Right. Sir, then now the concluding remarks by you and by Dr. Dwivedi, sir, and Dr. Tapas, sir. Sir, concluding remarks, sir.
I think
My
yeah,
concluding
please.
remark is that the father of stroke neurology was C. Miller Fisher. And when we were reading the textbook of stroke, his famous quote was that neurology was learned stroke by stroke. So in olden days, a patient will have a acute deficit. They would note down all the deficits. Then when the patient would die, they would do a post-mortem study and find out where was the lesion. That is how all the lesions were syndromes were described and their localization was found out. So if you understand stroke, then you have understood the art of localizing the lesion. So neurology was learned stroke by stroke, a famous quote in stroke medicine. So understand all the syndromes because they come as a group, but they tells, like in this case, what was missed was that vestibular nuclei is definitely involved in this patient. In lower pons, you find the vestibular nuclei, the upper vestibular nuclei. So probably we need to, because in this era of MRI, it is very easy in any acute neurological deficit to get an MRI done. But if you make a diagnosis beforehand with localization and then send an MRI and confirm that is the importance of a neurologist, and not just sending the patient for MRI.
Absolutely right. And
True, sir.
my
Hmm.
saying to residents will be basically go from very basic. What the teachers has taught us is once you are taking a history of patient, your aim is to find out what is the site of lesion. By the and at the same time, you should be able to decide what are the most likely etiologies. Etiology doesn't mean that you are absolutely pinpointing multiple sclerosis. But at the end of examination, you should be able to identify whether there is a site of lesion is single, multiple, central, peripheral. What are the points for What are the points against? History is acute, subacute, or chronic, because etiology comes with the branch. Suppose demyelination. Demyelination occurs only in neurology. Once you have identified that the patient is suffering from acute central neurological disorders, then you will think of central demyelinating disorders. Okay, so by the end of history, you should be with a hypothesis: what is the most likely site of lesion, and what is the most likely etiology. It will not be single; it may be two or three. Then you come to next examination. It is not only neurological examination at the same time. It is complete examination, including examination for all the rest of the systems, which will help you in finding out the etiology. Like I told you, rheumatological disorder. Patient may present initially with neurological problem, but he may be suffering from a rheumatological disorder to which he has not paid any attention. So complete systemic examination and your neurological examination should be there, whatever, to prove or disprove whatever the hypothesis you have created after completion of your history. Third, because there are many investigations, whatever the hypothesis you have created, finally you would have reached to one or two diagnoses after history and examination. You tailor your investigation accordingly. Suppose you decide this patient, suppose, doesn't have a history of dizziness and vertigo, presents only with diplopia and facial nerve palsy. Your approach will be different. Okay. If patient started with dizziness, vertigo, diplopia, and facial palsy, your lesion site becomes different. Your etiology becomes different. So on examination, on systemic examination and examination which is dedicated to your hypothesis, that helps you identify what is the site of lesion and what is the nature of lesion. Then you can identify the pathophysiology. What are the possible pathophysiology? Because third comes the without, if you cannot explain the site of lesion and through etiology, pathophysiology, it means you are not done a complete workup. Once you are, if you are going, suppose specifically, if patient doesn't have a congenital heart disease, and you get a MRI of this patient done to localize a lesion, and lesion shows that there's a pontine lesion, of course, then you will start thinking whether this acute lesion is, what are the possible acute lesion which I've already discussed, whether it is infarct, whether there's a demyelinating lesion, whether there's inflammatory lesion. Unless until you will ask, especially to neuroradiologists, that I am having these two possibilities, please identify. Suppose you have suspected demyelinating lesion, you will be going in this patient for MRI of spine also. If suppose you find a lesion in spine, spinal cord, or you find a lesion in orbit, means optic nerve, then you are certain that you are dealing with a demyelinating lesion. Okay. So history, then hypothesis, confirmation of hypothesis by examination, and whatever hypothesis you are left with. By the end of examination, you should not have many hypotheses, at the most two or three, and tailor investigation according to that and plan investigation according to that. Because so many investigations in neurology, you cannot, like MR angiography you suggested. Okay, fine. But you should, before ordering any investigation, you would think, what is the purpose? What problem it is going to solve in this case for me? Okay, so that is my message, that go to basics, then investigations, then find out the pathophysiology. It is not must that you are always reach to a diagnosis. Examination, it is always, in any exam, always examiner wants that your approach should be right.
Yes, sir.
I have a small comment. If the chair allows me, I can. So I have learned a lot personally. So regarding, can the person be muted? Because a lot of noise coming.
Yes.
So from actually for the residents, my take is treating a stroke in a patient who is having Eisenmenger is notoriously difficult because of the delicate hemodynamics. Once the stroke is there, only we can go for treatment. But to avoid stroke, fluid management, avoid dehydration at all cost, Dehydration worsens the hyperviscosity and increases the risk of further thrombosis. So judicious use of fluid, number one. And number two, secondary stroke prevention, because this is basically a clinical dilemma. So anticoagulation is generally indicated for paradoxical emboli, but Eisenmenger patients have a high baseline risk of spontaneous hemorrhage also, especially pulmonary hemorrhage and hemoptysis. And the decision between antiplatelet therapy like aspirin and anticoagulation therapy like warfarin or DOAC requires basically a multidisciplinary discussion between neurology and the cardiology and the internist. So that is my take on this particular patient. And lastly, phlebotomy, though used previously, routine phlebotomy is no longer recommended right now for Eisenmenger unless the patient is highly symptomatic from hyperviscosity, like headache, visual disturbance, and their hematocrit is typically very high, more than 65%. And if performed, it must be isovolemic. That is simultaneous fluid replacement should be there. The role of pulmonary vasodilator in the form of long-term management is also considered. So that is my take. Thank you.
Okay, sir. Now we can wind up and request Dr. Virmani, sir, to deliver the concluding remark.
Ma'am, please take up some questions from the chat box.
Okay, fine. Okay. Okay. Sir, Dr. Vinagwal sir, there is one question. Why is convergence usually preserved despite severe horizontal gait dysfunction in 8.5 syndrome?
Because the pathway for convergence is different.
Yeah.
It's basically both third nerve should be intact. Okay. It is not a connection between third nerve and sixth nerve or PPRF. It's basically individual third nerve should be intact. Edinger-Westphal nucleus should be intact. If these are intact, then patient can have accommodation. Because if patient third nerve is working, patient can have a medial rectus movement, then you can find accommodation present. Because we are not, in this case, third nerve is not basically affected. It is a basically connection and PPRF which is being affected.
Correct, sir. Sir, next question is to Dr. Shamsher, sir. Sir, there's one question. Is 8.5 syndrome undiagnosed due to inadequate bedside ocular motor examination?
No, it is not a very common condition amongst the stroke symptomatology. Amongst the various syndrome with which stroke presents, it is not very common, but the consequences of missing it is grave. So as a part of our teaching curriculum, and let me tell you one more thing, that there was a study where they compared clinical examination versus MRI finding in diagnosing whether the vertigo is central or peripheral. They found that clinical examination is superior to MRI. So clinical examination of a vertigo patient is very important, and this was a landmark paper from Korea that was published in Stroke, the EHA journal, where they compared clinical evaluation versus MRI evaluation of a patient of vertigo. Clinical evaluation was superior to MRI because MRI sometime in the posterior circulation, particularly in the brainstem, takes 6 hours to show up the infarct. So second MRI might show up the infarct, whereas the clinical evaluation is very precise as soon as the patient arrives. So examination of a case of vertigo, how to examine, it is an art, not taught routinely in wards.
Absolutely, sir. Absolutely true, sir. And rather, eighth nerve is the most neglected cranial nerve, I must say. Seventh nerve is the most examined cranial nerve.
Yeah.
And eighth nerve is the most neglected cranial nerve.
Yes, and a vertigo is the students. I remember a student also, you just skip it.
Yeah.
No need to study vertigo.
Yeah. It's around as far as the emergency department presentation of acute vestibular syndrome, is around 5% of the patients comprise of emergency department visit all over illnesses. Out of this, around 5% present with acute stroke presentation. Out of this, 20% of the patients have a negative MRI, as already Dr. Shamshir said. And these 20% patients can have a negative MRI even up to 24 hours or 48 hours. So you rely on these patients basically on hints plus test.
Yes.
Which is a absolutely clinical test, and the emergency department physician should know it, because at that time you cannot miss thrombolysis if a patient needs it. And the most important finding besides this, which I have discussed during the history taking, if a patient has a significant disability in walking, he needs substantial support to walk, patient presenting with acute vestibular syndrome, there is a highly likely possibility that there is a central cause for it.
So teaching the hint plus in the ward is important. We can't take that up here in this setting, but hint plus needs to be taught so that they can pick up the etiology of the vertigo.
Yes, sir. True, sir. True. Thank you, sir. So now, sir, I shall wind up and hand over the mic to Dr. Anil Virmani, sir. Thank you, sir.
Thank you, Dr. At the outset, let me welcome Dr. Hemshankar Sharma, our new president-elect, who will be taking over in October. I must congratulate both the PG students for wonderfully presenting the case, a detailed neurological examination, and wonderful the way they went through the differential diagnosis. And I'd like to congratulate the experts, especially Dr. Agarwal and Dr. Shamshad, for wonderfully eliciting their expert comments. I mean, I've learned a lot today. And of course, Dr. Tapas, who had a holistic approach and looked at the cardiac side. Now, 2 or 3 take-home messages from here. Any patient admitted in any ward should have a holistic approach. Here, for example, this patient, if his congenital heart disease was taken care of when he had his first embolic stroke, possibly that time he didn't have a reversal of shunt, and it was ASD would have been closed, he would never have got this problem today. Today, unfortunately, we are late. Surgery has no role. So that is the problem. Now, third, as mentioned by the neurologist, lot of time, clinical examination is more important than any investigation like MRI or CT. And they very clearly said it, especially in vertigo dizziness, simple clinical examination can give you the right diagnosis. And again, thank you, Dr. Smita, for your wonderful team. You and Deepak are doing an excellent job. Please continue.
Thank you so much. Thank you for your blessings, sir. Thank
My
you so
best
much.
wishes.
Thank you.
Thank you.
Over to you.
Thank you. Thank you for inviting. Thank you for the nice
Thank you.
meeting.
Thank you for the nice. Yeah.
Over to
Thank
Dr.
you.
Lohani.
Yeah. So thank you, everybody. And it's time now for vote of thanks. So may I request our Honorary Secretary, Dr. Abhishek, to propose a vote of thanks.
Thank you, sir. A lot of thanks to founder president, sir, dean, sir, all the seniors. And basically, this CME was entirely coordinated by Dr. Deepak Das, and he has promised that for the PG curriculum, he will help me in further proceeding also. So I request Dr. Deepak, because he has done so much of work for the CME, to propose vote of thanks on behalf of me. So in details, in fact. And my regards to all of you, sir. And pranam to all of you.
Thank you.
Dr. Deepak, please.
Thank you, Abhishek sir, for giving the opportunity. And I am thankful to everyone, respected President Dr. K.K. Parikh sir, A.N. Rai sir, founder president, our Lohani sir, S.K. Gautam sir, Hem Shankar Sharma sir, our expert faculty, Dr. Vinay Agarwal sir, Samsher Dwivedi sir, Tapas sir, and Smita ma'am for giving and our postgraduate students. So I express my heartful gratitude to Parik sir for his inspiring welcome address and encouragement towards academic excellence. I sincerely thank A.N. Rai sir for his valuable blessings and motivating words, which continue always to inspire us each and every time. And sincere appreciation goes to S.K. Gautam sir for introducing our esteemed faculty, setting the stage for an enriching scientific session. I am thankful to K.K. Lohani sir for uh, the, uh, uh, welcoming everyone. And I extend my deepest gratitude to our Smita ma'am for conducting today's session with great academic insight, and our expert panelist, Dr. Vinay Agarwal sir, Dr. Samsher Dwivedi sir, and Tapas sir for sharing their invaluable knowledge, practical experience, and constructive guidance during the interactive discussion. I congratulate Subra and Ritesh for excellent preparation and presentation, and thanks all the faculty members and participants whose active involvement made this session meaningful and educational. So uh,
Here, I would like to thank Dr. Vinay Agrawal, sir. I must tell the house here that Dr. Vinay Agrawal is the topmost neurophysician of Bareilly. He is the most sought after neurophysician of Bareilly. His appointments is delayed till 6 months. We get his amount appointment 6 महीने तक चलता है सर का. And I really thank sir कि आपने टाइम निकाला और आप हमारे बहुत ही फ्रूटफुल सर इंसाइट आपका विजडम हमें आज प्राप्त हुआ. आपका सर बहुत बहुत धन्यवाद.
थैंक यू वेरी मच. थैंक यू.
सबसे बड़ी बात है कि बहुत छोटे समय में, बहुत कम समय में सब लोगों को कल मैंने फोन किया, सबसे रिक्वेस्ट किया, और सब लोगों ने होल हार्टेडली एक बार में सब लोगों ने हाँ बोल दिया.
Deepak, I am also here. Don't forget me.
वही फिरमानी
सर आप तो गाइडिंग फोर्स है सर. आपने बरेली में आकर हम लोगों को इतना उत्साहित करा है कि हम लोग अब बहुत स्ट्रांग वे में जा रहे हैं, मुझे लगता है.
और सब लोग जो है, सबको एक बार फोन करके बस बोलना है एवरीवन एक्सेप्टेड कि हाँ मैं एकदम हूँ, ये अपना प्रोग्राम है, अपना कार्यक्रम है, हम लोग सब लोग हैं. और सक्सेस जो हमारी ECME का है वो वी हैव मोर देन 60 पीपल वेर ज्वाइंड एंड फॉर
62
मोर देन 60 पीपल जो है लगातार कंटिन्यूअसली 1 घंटे से ऊपर. वो इतनी अच्छी जो बोलते हैं कि वो एक कथा चल रही थी और कथा में सब डूबे हुए थे. कथा चल रही है, किसी को हटने का मन नहीं किया कि हाँ भाई कहीं पे बोरिंग लग रही है. और क्लिनिकल एग्जामिनेशन के बारे में जो सर ने बताया, दैट इज मोस्ट इम्पोर्टेंट. आज के पूरे हमारी इससे सीख मिलती है कि हमें क्लिनिकल एग्जामिनेशन अच्छे से करनी चाहिए. तो और उसे हमें इन्वेस्टिगेशन से मैच करना चाहिए, ना कि इन्वेस्टिगेशन से हमें चीजों को मैच करना चाहिए. तो इसके साथ ही थैंक यू ऑल ऑफ यू फॉर योर ग्रेशियस प्रेजेंस, वैल्यूएबल टाइम एंड कंटिन्यूड सपोर्ट. और अंत में जो है टेक्निकल सपोर्ट और बैक एंड स्टाफ जो है उनको भी बहुत बहुत धन्यवाद, क्योंकि वो सब लोग जो है इन सारे जो है सीमलेस प्रोग्राम के लिए उनका सबसे बड़ा हाथ है. थैंक यू एवरीवन. गुड नाइट.
सबसे ज्यादा कॉन्ग्रेचुलेशंस आपकी टीम को, मैडम को और आपको.
अच्छा,
बहुत अच्छे से,
बहुत बढ़िया, बहुत ही बढ़िया रहा, बहुत ही बढ़िया. अभिषेक, आई वाज सरप्राइज्ड कि हमको पता नहीं था बरेली से सारे लोग हैं इतने. बरेली मेरा एक स्टूडेंट भी है, राजेश महाजन.
क्या है सर बरेली आपका क्या है बरेली?
बरेली में राजेश महाजन है ना, न्यूरो
सर्जन. बिल्कुल
वो मेरा स्टूडेंट है.
अच्छा, ओहो
हाँ, he is my student.
ओहो, मेरे हस्बैंड उन्हीं के ही उसमें काम करते हैं।
अच्छा,
मेरे
अच्छा,
हस्बैंड, हाँ हाँ हाँ, अरे सो
Okay,
नाइस ऑफ
okay.
यू सर।
You tell him that Dr. Hemshankar Sharma was there and asking for
ओके सर,
you.
मैं बिल्कुल कहूँ, कल ही बात करती हूँ सर। थैंक यू सर।
हाँ, okay,
हाँ,
thank you,
ओके
thank you.
सर, राइट
Okay,
सर,
okay,
थैंक यू,
okay,
थैंक
bye,
यू,
bye.
ओके बाय सर।
Thank you, sir. Thanks a lot. Good night, sir.
Bye, good night, Abhishek.
So thank you once again, everybody. Good night.
हाँ सर,
See you.
लोहानी सर,
Yes, sir.
बहुत बहुत बढ़िया सर प्रोग्राम है, बहुत अच्छा बैकग्राउंड डिजाइनिंग है। मैंने कांग्रेचुलेट किया अलग से इसको, आदित्य को, कि कितना सर सोबर सोबर वे में प्रेजेंटेशन है, विदाउट यूज ऑफ एआई।
वो तो ही में रखे हैं इन द एरा ऑफ एआई क्लिनिकल स्किल। पता लग पड़े हो ना।
वो तो ठीक है सर, लेकिन जो हम लोग का दिख रहा है बहुत ही सोबर और बहुत ही सुंदर दिख रहा है, बहुत, जिसमें कि डिटेल्स दिख जा रही है। नहीं तो बहुत ज्यादा कलरफुल होता है सर, डिटेल्स ढूंढनी पड़ती है कहाँ पे।
देखो सब्सटेंस रहता है तो फिर कलर की जरूरत नहीं पड़ती है
जी जी जी
ना,
जी।
ना लाइफ में ना पेपर पे।
अरे कलर तो लोहानी जी अपने हैं। कलरफुल पर्सनालिटी है ना।
जी
चलो
चलिए
ठीक है।
साइंटिफिक बन गया, लेकिन हाथ बहुत लंबा है, इसको अब एग्जीक्यूट कीजिए मिलजुल के सब लोग।
जी
नहीं
जी
हो
जी।
जाएगा सर, सब हो
80
जाएगा।
स्पीकर से अभिषेक देखे होगे, 80 स्पीकर है।
हाँ सर।
तुम सोच सकते हो कि कैसे इसको एकोमोडेट करना पड़ा होगा। 4 महीना जिसको कहते हैं कि एकदम 1 तारीख को एकदम डिसाइडेड था कि इसको निकाल देना है। चलिए ठीक है।
एकदम निकल गया। ओके सर, गुड
ओके,
नाइट।
थैंक यू, गुड
गुड
नाइट।
नाइट सर,
गुड
गुड नाइट
नाइट,
सर,
गुड
प्रणाम
गुड
सर,
नाइट, गुड
सबको प्रणाम।
नाइट।
नाइट।